Um, this is kind of a tough subject. I'll try to make it go through it in 20 minutes. What I'm going to do is I'm going to first reverse the topics. I'm going to talk about role of hemodynamics in maturation first, and then talk about managing the high flow because one leads into other. I'll try to define maturation problem again and talk about the current concepts about non-maturation, which has been briefly touched upon by earlier speakers. Physiological aspect of maturation and role of hemodynamics in that, and talk a little bit about clinical implication. Then I go into the high flow and management aspects. So what is the frustration now? The frustration is that we think simple surgery, joining a vein to the artery, but failure rate is very high. And failure obviously happens many a times because of the narrowing of the lumen, causing stasis and thrombosis. Those that survive that and mature are not cannulatable sometimes because of their tortuous veins, or there is aneurysmal dilations happening over the time, or high flow complications. The frustration is that we cannot predict and say in whom this happens, when this happens. You think you have done a great surgery, next day it's clotted. So that is the problem, right? And so far we have said that that happens because of a lot of these factors, like everything under the sun has been blamed. Unfortunately, the mother-in-law is not there on that. So, but everything has been blamed there. We have said surgeon factor and everything else. And then we have dissected this out, what happens thereafter. We know there's platelet activation, there is increased production of free radicals, upregulation of growth factors, degradation of extracellular matrix, smooth muscle hypertrophy, finally smooth muscle migration, and then you get a VNH. So we know the pathophysiology very well. This has been very well dissected out. Based on the bottom part of it, that is downstream event, not the upstream events, we have tried everything under the sun. We have tried anticoagulants, we have tried more specific ones, cyclooxygenase inhibitors and everything else, and now we have also tried local treatment like RAPs and stuff like that. None of them have yet shown a significant difference. So now, probably we should step back and rethink. So if you go back and pull, you can Google this and get this graph. This is just an injury healing response for a simple skin cut. But what is interesting is if you look into that, it is the same factors we have seen in vascular biology. There's MMF, upregulation, platelet aggregation, smooth muscle. Bottom line is it's the same healing response. So you go back to pathology books, one of the oldest ones, you go and see, it clearly says that intimal thickening is a stereotypic response for any vascular injury. And that injury could be anything. It could be toxic injury, it could be balloon inflation, it could even be alteration in blood flow. It also says that sometimes the injurious agent is timely way, goes back and a vessel gets reepithelialized. This response may not come. So now let's go back and see all the factors. We talked about technical factors, right? So if the technical factors were the cause for non-maturation, why, if the same surgeon does a surgery in two different places, it has not worked in the same patient, but the third one works like a charm? It is the same technique, same surgeon, same instruments. So it's difficult to believe that technical problems are the cause for this problem. Moreover, if it is technical problem, it should be only at the area of the technique, right? Why do you get a stenosis way further up? So I'm not saying technique doesn't matter. Technique does matter, but I think surgeons are trained enough to use atraumatic instruments and do a reasonably good technique, and not to back wall the vessel and things like that. Those things happen rarely. Then we start blaming the patient demographics, hematocrit, low cardiac output, and everything else. Once again, the same issue. Same patient had one access failed, but the next one worked perfectly fine. So probably the contribution of these are not much. What else we can look at? There are two things we need to look at which are permanent when we do an access. One is tissue alignment change. The second one is blood flow. So what happens to the blood flow? The normal flow is only about 40 or 50 to the limb, and it goes back to the heart in 10 different veins. As soon as you do the anastomosis and measure the brachial artery flow in the operating room, 40 becomes 400, which means 360 of that is going now in one vein. That vein had 5 mils of flow earlier because 40 was divided into 10 veins. Now it's got 400. Blood flow has gone up almost 100 times up in that one vein. And with every heartbeat, there is a push of blood into that vein. There is a tremendous amount of hemodynamic stress. and that is one of the most important injurious agent. As much as we think the blood flows inside the vein in a laminar pattern, that means a straight flow, if you carefully look at it, when the blood flows into the vein or in any vessel, it is called spiral laminar. It is like a bullet. It torques around its own axis, there's a torsion, and then goes forward flow. So it is a spiral laminar. That's why when you put an ultrasound at 90 degrees, you put a color Doppler, you see half of it is red, blood is coming towards it because it's spiraling, half of it is blue. So it's a spiral laminar flow. Now what do we know about this spiral laminar flow? We know that this spiral laminar flow in the areas of bends and twists becomes turbulent. And why this is important? There are enough studies in vitro as well as in vivo showing that when you have a smooth wall shear stress, which is associated with spiral laminar flow, you get production of prostacyclin, nitric oxide, which are vasodilatory substances. When this shear stress becomes turbulent or oscillatory, you tend to get production of vasoconstrictor elements. And believe me, every minute your blood is flowing into the vessel and you have this stress going on, no wonder you get problems or injury response coming up in areas of turbulence. Now, there's a branch of fluid mechanics, which is called computational fluid dynamics, which basically applies numerical methods and algorithms to analyze and solve the problems associated with flow, or associated with the fluid movements. Now, computational fluid dynamics has actually modeled AV fistula and shown areas of turbulence, and there is good clinical correlation with these turbulent areas and stenosis development. Like Dr. Todor said earlier, we know any angulation more than 30 degrees has higher turbulence associated with it. So what does this all mean? Does this have any clinical relevance? And we are talking about all those things. About 10, 15 years ago, we were working or playing around because I was convinced that this is something to do with the flow. So we tried to look at what we were doing. As a surgeon, we have been taught how to do the surgery. Basically cut the end of the vein. If you have a branch point, try to splay it open and put on the side of the artery. Now, if I were to do that, anatomically, the vein is sitting on the top left figure. You can see that. The vein is sitting above the superficial fascia. Artery is sitting deep to the deep fascia. They are not on top of each other. So if I have to move that vein to the artery, I have to move it to the side, then up and down, the second movement. The third movement is I'm cutting it at the vertical axis and putting it anastomosing in the horizontal axis. I'm doing 3 movements with this soft structure. If you do that, there is an elbow at some point, and at that elbow is the place where we always see the juxtaanastomotic problem developing. So is there some torsion there? Is there a way to get out of this problem? So we started working with this and tried to take away the third movement. And we did that just by closing the vein at the end. And instead of putting it to the side, we just brought it up and down. We just moved to one side, from the side on top of the artery, did the anastomosis from the front of the artery to the back of the vein. And we called it piggyback straight line onlay technique. And this is how that is done. We just, with the ultrasound, we find out where the vein is, where the artery is. We go ahead and close the end of the vein. We make an anastomosis, make a hole on the back, hole in the front. At that time, we didn't realize it had a lot more advantages. One is you can size your anastomosis to the length you want. You really don't want a 2 centimeter anastomosis or a 11 millimeter anastomosis on an artery. We'll talk about it a little bit later. So you can size your anastomosis. That's one of the important things. The blood flows from a circular lumen into a circular lumen. That's the second advantage. Okay? So this is how the SLOT technique was done. Obviously, we saw a big difference in the results. Our failure rate went from 30% in post-operative juxtaanastomotic problem to 6%. Recently, when this is one of the, Dr. Hull is the kind of inventor of one of those endovascular things, and we were talking, and he had done this computational studies with his engineers. Again, it showed the same thing. It showed that the anastomosis, which meets the SLOT technique criteria, has a minimal juxtaanastomotic problems. And if you see endovascular fistulae have minimal juxtaanastomotic failure rates. So we are doing more computational dynamic studies. This is another study we did where we are trying to see what is the effect of stenosis on the flow. So we generated some graphs. The left-hand side shows you the mean arterial pressure starting at 50, going up to 160. And on the top row shows you 5 millimeter length, 10 millimeter length, 15, 20, up to 60 millimeters. And the boxes below show you the flow. When you see there, if you have a stenosis of 2 millimeters, which is right on top there, and if you have a pressure of 50, mean of 50, that's the lowest pressure your patient can probably reach while you're on dialysis, you still have a flow greater than 500, even with the stenotic length of 10 millimeters for a 2 millimeter diameter. Okay? So that is good enough for that pressure to push that much blood through that vessel. We compared this to see if, we couldn't believe it, but we compared it with, went to the clinic, did the ultrasound, picked patients exactly matching that stenosis, and compared it and saw it was true. Okay, the difference was like 27% or something like that in the volume flow. It's published in the Journal of Vascular Access. So bringing it back to the clinic, what are we seeing? For dialysis, we need a flow of 150 mils to 500 mils, depending on the place. To deliver that flow, we need a fistula flow, maybe at most 600. But many of our access flows are way higher, much higher than that, and which is probably not required. So because the high flow is causing problems, people have even started saying that greater than 1,500 mils per minute is considered as a high flow access. Now, if you go back to computational fluid dynamics and see, if we make an anastomosis of 2 millimeters length, assuming the anastomotic width is only about 1 to 1.5 millimeters, it is capable of giving the flow required, 600 or more, very easily. But none of our anastomoses are that small, and maybe for two reasons. One is if you make that small anastomosis, it's very difficult to make one unless you use a my operating microscope or something like that. Number two, if you make that anastomosis in the post-op period when there is swelling, it is easy to occlude. So you can make an anastomosis like an arteriotomy and venotomy, especially if you're doing slot of around 3 or 4 millimeters. By the time you have finished putting the sutures with the manipulation, the anastomotic size will be around 5 millimeters diameter. So that is what we do all the time now because we have realized we don't need bigger holes. The problem is the other way. When you make bigger holes, like in a brachial artery, then you tend to get way higher flow. That's why if you see the steel and other problems, they are higher with, mostly associated with larger arteries, whereas smaller arteries don't get that kind of a flow. So it's ideal to find a fistula inflow on radial if you can at any given time. Because there are many other factors, but other than your anastomotic diameter, you require only a small anastomotic diameter, and what you do if you do a 5 millimeter anastomosis is more than enough to handle any kind of a flow requirement for dialysis machine. If you make anything bigger, you are putting a patient at a risk of high flow problems if the patient were to develop that. And that depends upon all the other factors which come in, the compliance of the system, the pump pressure, basically the heart. So all those issues come into. Now, the flow is determined essentially by length of the artery. So radial artery diameter is small, but length is like 15 or 20 centimeters, so that gives enough resistance. With radial artery, you don't get much high flow problems. So one of the ways to prevent high flows is to try to do the anastomosis small and try to base it on radial artery. Now, say you've done everything and the patient has a high flow. What does high flow do? You can easily classify high flow problems as three things. One is central effects, one is peripheral effects, and one is local effects, okay? So central effects are what? Cardiac effects. Now, believe me, these are extremely, extremely rare. I have about 125 patients, which I have been following for 5 years with serial echocardiography every year to see what is the effect on the heart. And there are 2 or 3 patients who have had heart-related problems. All 3 of them had some other underlying issue, which was kind of exacerbated because of the high flows. And these are patients who have flows over 1,500, most of them like 2.5 to 3 liters. So I'm not saying high flows won't affect the heart, but there's nothing to say that high flows are the major issue for cardiac problems. This association is definitely there, but it happens most of the time when there's some underlying heart problems. What are the peripheral effects? Peripheral effects, Dr. Vajrayani went over it in detail. I'll be talking a little bit about it too. There's ischemic issues. And what are the local effects? Local effects is aneurysmal changes in the axis. Most common cause for aneurysm is increased intra-axis pressure. And every time you stick a needle into a vein, there is an injury, there is a small hole, and the injury heals with fibrous tissue scar. And if the pressure is borderline high inside, which tends to be more associated with higher flows, you get dilation or weakness of the scar. Over a period of time, that area becomes a big aneurysmal change. So here is a patient who had a cephalic arch stenosis and had a flow of 1.5 liters, had a mildly pulsatile fistula. Within a short time, patient had a big aneurysm developing in the fistula within like a year or so. But in the meantime, somebody had gone in and put a stent in the cephalic arch. Obviously, there is stent narrowing. Now there is more obstruction to the flow. So the proximal vein is hypertrophying. When the vein hypertrophies in the same subcutaneous plane, it becomes tortuous. It's now tortuous. When it tortuous, it kinks on itself. There is more obstruction to the flow. There is clot forming. There is chronic thrombus inside the fistula. Eventually, when she came to me, she came with a thrombosed fistula. So bottom line is one of the common cause for aneurysmal dilation is higher intra-axis pressure. May not be very high, but it's a borderline high, and more borderline high pressure is associated with higher flows. So what are the distal effects? Distal effect is hemodynamic effects. So this is a normal flow in the axis. If you have a normal distal artery, you may have a high flow fistula, like a 1500 or 22 liter fistula, but then flow to the distal limb is still intact. Most of the patients with high flow fistula have this situation where, when they're on dialysis, when their pressure goes down, they may say, my hand is a little tingly or something, but otherwise they're all okay because the distal vasculature is okay. Now, if the distal vasculature has got problem, they're at a higher risk of developing hypoperfusion to distal axis because the distal artery has a very high resistance, or even at a lower flow, the blood going to the distal axis may be less. So they may feel it more. Now, high flow accesses are easy to manage because, like we said, if you measure the brachial artery flow and flow is 1500, I've got a lot of room to bring that flow down. I don't need more than 600. The question is, in the past when people tried banding, it all failed. People could not get it right. It either thrombosed or symptoms didn't go away. Because we didn't have any precision added to it. We have no idea what we are doing. We don't know how tight the band should be. We had no measure of how much flow was going down. Now remember, it's not just the flow. Flow is an indicator of distal hypoperfusion. Perfusion is a function of flow and pressure. So just don't be under the impression that by reducing the flow, all problems will go away. It is the improvement of perfusion. So we have to learn to differentiate between where is hypoperfusion related, major component of the hypoperfusion being flow, versus major component of the hypoperfusion being hypoperfusion and low pressure because of the bad vessels. So if you have high flow, you have major brachial artery flow, any patient with a symptomatic ischemic symptoms in the hand, you measure the flow, you have a high flow. Easy way to manage that is to do a banding. And when we talk about banding, Dr. Vajrayana will show you the Miller procedure. We call it an internal sizing, that is, you're taking a 4 millimeter balloon from inside the vessel, or you can do an external sizing by putting a dowel around it. That's what we do in the operating room. But regardless, whatever you do, when you're doing it, measure the pressure, measure the flow. You can easily measure the brachial artery flow. That's what we do, and we call it precision banding. If your flow was 2 liters, after you put that 12 French red rubber catheter, external diameter is 4 millimeter. You just keep it next to the vessel, put 2 or 3 ties around it. You have reduced it to less than 4 millimeters for the vessel. But after you put 3 ties and pulled out that catheter out of there, measure the brachial artery flow. If the flow is 600, you have done a great job. If the flow is 400, cut one of those bands, flow goes up. If the flow is 1200, put more another band, make it slightly tighter. So it's a very simple procedure to do, but you are doing it precisely to reduce the flow. Majority of the time, if it's a high flow associated problems, tend to go away with this procedure because you have reduced the flow and given one component of perfusion back to the hand, that is the flow component. Now, there are surgical procedures described. I mean, there is a revascularization using distal inflow. So this is a procedure which is used in brachiocephalic fistula. If you have a high flow fistula, you could distalize that anastomosis to a radial artery near the wrist or in the mid-forearm. Thereby, you are reducing the inflow to the vessel and reducing the flow. That is the procedure called Rudy. Then there is a procedure called DRAL. Now, DRAL is distal radial artery ligation. So this works in two ways based on where you're ligating the artery. If you ligate the artery right there, in that all radiocephalic fistulas have flow coming from radial artery and some reverse flow coming from the ulnar artery. That is normal. 80% of the patients have that. That is not still. But in some patients, when majority of the flow from the ulnar goes to the hand and hand flow becomes less, majority goes to fistula and patient becomes symptomatic, patient gets a steal. Now, if you have a steal symptom, you can ligate the artery as long as you have the intact palmar arch. That is distal ligation, and this is not flow reduction procedure. This is you are increasing the perfusion to the hand by reducing the flow, reducing retrograde flow in the fistula. Whereas you can do the same procedure in another way where you ligate it in between. Now, this is a flow reduction procedure where you are cutting it right in the middle. So you can do a DRAL. Now, rest of the procedures which I'm talking has got nothing to do with flow reduction, but it is something to treat steal. I just want to give you a physical concept how distal perfusion can be increased in patients.
Sorry, Dr. Shenoy, we're running out of time. Can you just summarize, please?
Okay, sure. So for people who don't have distal perfusion, you can increase the perfusion. Those are the other procedures which I think since we don't have time, since they belong to my talk, I can skip over those slides. That's good. So just to summarize the talk, the maturation problems are mostly related to the steal symptoms, mostly related to the hemodynamics of the axis. And by manipulating the hemodynamics of the axis, we should be in a position to reduce these problems to a great extent and increase the maturation rates. Thank you.